Prof. Marcus Hecker. Just a short bio. Prof. Marcus Hecker is the full professor of nuclear medicine and director of the Division of Nuclear Medicine at the Medical University of Vienna. He's also the deputy chair of the Department of Biomedical Imaging and Image-Guided Therapy in the Medical University of Vienna. He's a former assistant professor of nuclear medicine and head of cardiovascular imaging and research unit in the Department of Nuclear Medicine at the University of Munich. He's a visiting professor of several medical universities in Bosnia and Serbia. Prof. Hecker, thank you for your expertise. You may take the podium.
Thanks a lot for this nice introduction. Thanks for inviting me to this exciting Congress and to this fantastic city and venue. My topic is now advanced imaging of cardiac sarcoidosis. And we heard in the last presentation already parts of the diagnostic challenges we have and the therapeutic opportunities we have. And I will go mainly into what we call advanced imaging, MRI and FDG PET, including cardiac PET MRI, but I will also talk about the potential FDG PET has in terms of therapy monitoring, and will also introduce a few potential novel radiopharmaceuticals we could use for more personalized treatment in the future. But let me start with the general challenges we have in that disease, particularly if it comes to cardiac involvement. You see here an autopsy of a heart with sarcoidosis disease, and you see the white spots here, which are fibrotic areas in the heart, involving around 20% of the heart mass. And you can easily appreciate that if you try to biopsy, then the chance to get a biopsy failure or a sample error is extremely high. So it's around, if you do a blinded biopsy, you will achieve in around 25% of cases these typical non-caseating granulomas, as we had before. Even if you do, let's say, image-guided biopsy, you will end up with a probability of up to 50% to reach these typical areas. So we need other diagnostics than endomyocardial biopsy. What is mainly used in clinical routine is MRI and FDG PET. As it was explained before, patients appear with already diagnosed extracardiac sarcoidosis, where ECG changes or heart failure symptoms are present, and then you always have to exclude, of course, because of the limited prognosis of these patients, cardiac involvement. Other patients have primary cardiac symptoms, as we also heard before, and in both scenarios you will want to exclude cardiac involvement or diagnose cardiac involvement. And for those who have MRI available, the first step mostly is MRI, because you can not only diagnose cardiac sarcoidosis, but also exclude other reasons for ECG changes or heart failure symptoms, for example. Many patients have already, because of heart failure, get pacemakers, and the older pacemakers are not compatible to MRI, so you might start even with a perfusion scan FDG PET combination, but normally you start with an MRI. So if you have no typical late gadolinium enhancement spots, as we already saw in the last presentation, then you can nearly exclude the presence of cardiac sarcoidosis. But there are some patients which you reach in a very early stage, which might have FDG accumulation without late gadolinium enhancement in MRI. Otherwise, if you see these late gadolinium enhancement spots, then you can use FDG PET to differentiate chronic cardiac sarcoidosis from active inflammatory disease stages. And I will show you afterwards in detail how this works. For those who do not have MRI available, or for those patients who are not compatible with MRI, you can use perfusion scans, and there is a joint expert consensus document published in 2017, SNMMI together with ASNEC. And you see here different patterns of the cardiac involvement. So there are patients that have a total normal perfusion, but might have already a focal increase in FTG, so inflammatory stages without fibrotic or scar tissue. And you might also have these patterns, abnormal perfusion patterns, with at the same time increased FTG uptake, which could be a combination of fibrotic tissue, scar tissue with inflammation or without inflammation if you have no FTG uptake. So this is the way we can diagnose cardiac involvement, and we can differentiate active from chronic cardiac involvement and exclude cardiac sarcoidosis. What is important for us as nuclear medicines is how to prepare patients for FTG scans, because this is totally different from oncological FTG scans, so we have to prepare the patients. And the background for this is that, I have to check how I can look back. Yeah. So if we get the patients fasting, then the insulin level in the blood is low, and the glucose is not taken up via the GLUT4 transporters into the myocardial cells, because this mechanism is insulin dependent. Vice versa, if after a meal there is a high insulin load in the blood, and the FTG as well as the blood sugar is taken up by the GLUT4 transporter. So we have to have the patient fasting. And the good thing is that in inflammatory cells, the FTG and the blood sugar is taken up via the GLUT1 and 3 transporters, and this is insulin independent. So we can visualize and quantify the inflammatory cells activity, the metabolic activity of inflammatory cells via GLUT1, 3 transporters, and at the same time suppress the myocardial uptake for FTG. And this is really important because if this does not work, and I will show you examples, then you have these kind of diffuse uptakes in the myocardium, and you cannot really use then the scans for differentiation of cardiac involvement. And how do we prepare the patients? So the patients should fast at least 12 hours, and ideally should get a high-fat, low-carbohydrate meal before. We don't do that, to be honest, but what we are doing is to give intravenously non-fractionated heparin 15 minutes before the FTG injection to stabilize the FTG lowering effect in the myocardium. And then you can combine or not combine with stress-rest perfusion imaging. It should always be, of course, ECG-gated. And I would always recommend to add a whole body scan to exclude extra cardiac involvement for those patients who have a primary cardiac sarcoidosis. MRI, how is that done? This is a routine MRI, includes late gadolinium enhancement scans, functional scans of the left ventricle, volumes, and ejection fraction. You can do more today, and I will show you examples with T1, T2 mapping sequences which add diagnostic information to the standard MRI alone. And what you find then is these late gadolinium enhancement spots here, and the pre-speaker already mentioned that this can be epicardial, endocardial, transmural, but it's mostly a spotty disease that has a typical phenotype in MRI. There are meta-analyses out comparing MRI, late gadolinium enhancement, with FTG PET alone. And what we know from these meta-analyses is that the accuracy and mainly the sensitivity is higher in cardiac MRI. So if the question is to detect cardiac involvement, so cardiac sarcoidosis, then MRI is better than FTG PET alone. And this is by nature so. This is no surprise, because with FTG, we only can detect active inflammation and not the scar tissue, because we prepare the patient, as I said before. So this has a logic. And it has also logic that the prognostic value of MRI compared to FDG PET alone is better, because in MRI we detect fibrotic tissue, scar tissue, and you know, the more scar tissue in the left ventricle, the worse the LV function and the higher the probability for VTs or other arrhythmic events. So this is shown, and so the question is then, what is the strength of FDG PET, and why should we use then FDG PET if MRI is so good? And then we come to the differentiation between active and inactive sarcoidosis, so between active and chronic involvement of the heart. There was one study out, it's also an MRI-driven study, but nicely shows what opportunities we have to differentiate. There were 43 patients included with histologically proven extracardiac sarcoidosis, and all these patients had a suspected cardiac involvement. Interestingly, 7 patients had to be excluded because they were not well prepared for the examination. They had these diffuse uptake patterns, so FDG uptake was not completely suppressed. Can happen, should not happen too often. And then they did first late gadolinium enhancement MRI scan. If positive and the PET was positive, then the diagnosis of active cardiac sarcoidosis was made here. If the PET was negative, then it was a diagnosis of chronic cardiac sarcoidosis without active inflammation. If LGE was negative and the PET was positive, then those who had also positive T1, T2 mapping were diagnosed as active inflammation. And if the PET was negative, and the T1 mapping was positive, it was staged as chronic cardiac sarcoidosis. If all were negative, it was staged as no cardiac sarcoidosis. You can discuss this approach, but this nicely shows that if we have no biopsy results, we have not really a gold standard. If no, let's say, follow-up is performed, then you need algorithms underlying for your methodology in the study. So T1, T2 mapping overruled both the late gadolinium enhancement and the PET scan in the study. And what you see here then as a result is that in cases of negative FDG PET, when the MRI sequences were negative, there was no cardiac involvement diagnosed, so 14 of 19 patients here. And when the MRI was positive, 5 patients had then chronic cardiac sarcoidosis. And on the other hand, if PET was positive, there were 13 patients with active cardiac sarcoidosis. And when the MRI sequences were negative, then it was rated as false positive PET. As I said before, you can discuss that, but this was the study approach. And I show you some examples here. This is a patient typical pattern here in the inferior wall, the late gadolinium enhancement, and at the same time FDG uptake, so active cardiac sarcoidosis. And on the other hand, you have here epicardial and in the inferior wall, these late gadolinium enhancement spots without FDG, and this is a chronic cardiac sarcoidosis. And this is a way how they use the T1, T2 mapping. This is a patient without late gadolinium enhancement, so you normally would exclude the patient for cardiac sarcoidosis. But this patient in the lateral wall has this FDG uptake. The T1 mapping was negative, so no additional information here, but the T2 mapping was rated as positive in the lateral wall, and so we had an early disease without late gadolinium enhancement, but active parts are in the lateral wall. So again, active cardiac sarcoidosis. So this is the way we can use these advanced technologies for differentiating the different diseases. Another clinical challenge always is to differentiate between isolated cardiac disease and extracardiac involvement. This is, of course, relatively easy in these cases where we have definitely both extracardiac and cardiac involvement. And these isolated cardiac sarcoidosis only are really rare cases. I've really rarely seen these cases because normally you have at least some positive lymph nodes in addition to the heart, and also statistically, if you look in publications, it's a relatively rare phenotype. Regarding the heart uptake patterns of FDG, it's not really a significant difference between a group of patients that first presented with heart sarcoidosis and those who first presented with extracardiac sarcoidosis. The only differences are in the right ventricular involvement in the atria, where those patients who present first with cardiac sarcoidosis have more advanced patterns and involvement of the right ventricle and the atria. And this translates also to prognosis, because what we know from previous studies is that those patients who have atrial involvement, so PET positive here, have a better prognosis for the incidence of atrial fibrillation in the follow-up. So we should always look not only on the ventricles but also on the atria and look if there is uptake present or not. This was also true in the different regression models calculated, and you see here that the atrial uptake was the most predictive for the appearance of atrial fibrillation in the follow-up. How do you diagnose that? You see here a patient without atrial involvement, and here the asterisks here all show in 3 different patients atrial involvement. And those patients with atrial involvement really got in the follow-up atrial fibrillation, and these patients did not get. So we have additional information, not only diagnose cardiac sarcoidosis, differentiate active and chronic, but also have prognostic features we could use. But the final goal always is, of course, to guide treatment and to improve the prognosis of the patients. And there are also studies out, and this is a domain of FDG PET. So this study investigated 59 patients with active inflammation diagnosed by, with active sarcoidosis diagnosed by FDG PET. And this was a study that evaluated the efficacy of additional methotrexate therapy added to prednisolone alone. And you see here that FDG was heavily used. So first of all patients got a standard prednisolone treatment, 30 milligrams per day for 6 months. Then another PET scan was performed, and then the patients were stratified and randomized into those who responded to the treatment and those who had a poor non-response to the prednisolone treatment. And the non-responders in this group, methotrexate was added to prednisolone, and the others got only maintenance therapy for prednisolone. And then after 12 months, again, those who had recurrent disease were again treated with a combination of prednisolone and methotrexate. And then again, FDG was done to check for the response to the therapy. So we can use these methods for evaluating the treatment response to prednisolone or combination therapies. And you see here that the PET responders had the much better prognosis as compared to the PET non-responders. So you can use this information, and this is also used in the clinical routine. It's relatively simple to find the responders because you have patterns like this here, FDG uptake in the left ventricle, which is gone in this kind of, let's say, super responder. But you have these pure responders where nearly no change in the uptake patterns is found. Of course, with the upcoming novel treatment options we have, the new immune modulating treatments, we should enable the clinicians to identify potential molecular targets for treatments. And we have many of those in immune cells, so not only metabolic targets like FDG I talked about, but also FLT or amino acids, fatty acids. But we have also receptors expressed on the surfaces of lymphocytes and macrophages like somatostatin receptor subtype 2, CXCR4 receptors, and also hypoxia markers. All these markers were already investigated in small study cohorts. I show you just some examples. We don't have yet controlled structured studies in this relatively rare disease, but you see here that you can use the gallium DOTA-NOC targeting the somatostatin receptor subtype 2 of macrophages and lymphocytes. And you see here spotty uptakes in the septal and the lateral wall, and this is not identical with the uptake in FDG. We do not yet know what this exactly means and how we can interpret these findings. We have similar patterns in FLT imaging with the caveat that we have a relatively high liver uptake, so this is probably not the best tracer to replace FDG. The background for the thinking always is that an ideal tracer would not need this preparation phase with a long fasting, but FLT is probably not the best tracer. There's also studies out with F-MISO. You see that the uptake here is not very high, so it's also not a very good tracer. What could be interesting is FAPI, because the FAP compounds are targeting the activated fibroblasts, and this is a very early stage of fibrosis, and you know that the fibroblasts are regulating also the immune response in that area. So this could be an interesting option in the future, particularly if there are antifibrotic treatments present. So let me summarize. I think cardiac MRI and PET are showing different aspects of cardiac sarcoidosis. MRI more the fibrotic states, scar, FDG more the inflammatory states, and I think FDG is superior for treatment monitoring, and in the future we should use novel radiopharmaceuticals to better personalize and individualize our treatment strategies. Thank you very much for your attention.
Thank you so much, Prof. Hecker, for that stimulating walk through cardiac sarcoidosis.